So pediatric cataract surgery per se is not the same as adult cataract surgery, because adult cataract surgery patient comes, get the surgery done, pays upfront and goes back home, maybe comes for a refraction after 4 weeks and that's the end of the story, maybe a VAO after 6 months or 1 year or 2 years. Here the problem actually starts after the surgery. The surgery is the easiest bit, but planning the surgery and the follow-up is, I think, lifelong. So I think I'll just come to the surgery straight away. You should know about the anatomy of the eye. This eye is not a small adult eye, but it's an eye which has got a thinner sclera. It's got a cornea which is very steep, and it's got an axial length which is smaller than the normal. So these are the parameters you have to look into, and as I think each of the speakers will come and talk about the IOL power calculation and all these things will become important. The important thing is that by the end of 6 months, your VER is as good as 20 by 20 of an adult. So you have to do these surgeries as soon as possible. And please operate the patients which need the surgery, not the ones which are clearer. Okay, so I think I'll go to the surgery. The important thing here is that you need a very good anesthesia team. Parent counseling is the most important point here, because they have to be told, they have to come every time for a suture removal or refraction, and if the kid is about 6 months to 1 year, they need examination and anesthesia. Systemic workup is important, and due course we'll cover that up. So starting with the intraoperative surgical steps, I think the most important step which people should know about is how to properly expose the eye. You use the rings which you use for the adults. They don't work for the kids because the head is small and the rings are big and the head keeps moving. So you need to have rings which are less than people for less than 6 months, for 1 year to 6 months, 6 months to 2 years, depending on the size of the skull you're handling. Your speculums should be specifically made speculums meant for these age group, otherwise your exposure won't be good. The trick is to put a shoulder band. You put a little rod under the shoulder. The moment you put it under the shoulder, the neck goes up and the head falls back. So the eye will get more aligned. Okay, so this is a very simple thing, but this is required during the surgery because you just saw the last session. If you want to have a good recording, you have to be end on the retro. If you have to have a retro reflex, you have to have the eye parallel to the microscope. No shortcut. Okay, now it's always better to have 3 incision surgery in these patients because you make 1 incision here, 1 opposite, and 3rd here. So when you're using the biomanual, you can actually go 360 degree all around under the capsule, and you can take the cortex all over without much of a problem. Okay, so if your chamber goes shallow after making 1 incision, please do not get scared. You go ahead and put in viscoelastic, do the air, dye, whatever you want to do, and you can come back to make the incision later on once the eye is taut with the viscoelastic. Alright, so once you've done the thing, you have to stain the anterior capsule because without that, access won't be possible. There's no contrast there. Use 1 in 10,000 adrenaline, which is intracardiac solution. The moment you put in a dash, it opens up. Most of the capsules, anterior, this thing will open up, iris. So you put a Trafen blue under the air. You don't want the endothelium to get stained. And once that's done, try to take out the dye from all the openings. So what happens, every time you go in, you have a markation that that's the incision and you won't be destroying the endothelium on that side. Okay. Now, anterior capsule management is different from the from the adults because here it behaves a little differently. It's more elastic and everybody's scared of doing the anterior capsule rhexis. But mind you, after this, I think presentations and all, I think you'll be more confident and able to do by yourself. And you have to cover this lens all around 360 degree so that there's no VO formation. So the rhexis size has to be very, very accurate. So if you can remember this photo, you see there's one dome here and one going backwards. That's the anterior capsule for you and that's the posterior capsule. So when you want to do anterior capsule rhexis, you have to push the dome down because you don't want the rhexis to slip down. It's a spiral, it'll go down, it'll go out. Whereas when you're doing a posterior rhexis, you don't have to overfill. We'll come to that when I'm doing that. So what you need to do is you need a good viscoelastic in these patients. You already stained the capsule, pupil is well dilated, and you go and start from 6 o'clock, try to squeeze out the bubble. If the bubble is there, sometimes suddenly the bubble comes out and your chamber collapses, so that should be avoided. You give a nick from the side port. You give a nick from the side port is a vertical nick, and that's about it. Don't think you're a Superman and you can do a rhexis with a needle in pediatric age group, 6 months, 1 year, 2 years. It's not going to happen. You might be lucky to get in 1 time, but you need a Utrata forceps or intravitreal forceps, whatever you can catch hold of, and whatever you used to. And you start holding, grasping, and rotating again and again. The trick again is that if you're doing hold in adult for 5 to 6 times, here you use 7 to 8 times, little extra. So you go for small quadrant to quadrant, and you can actually get a good rhexis in all patients. And you all are used to using Utrata in the adults. So once the viscoelastic is good in the eye, it works like an adult capsule only because it's pushing the dome back. Just remember the first video, the dome has to be pushed backwards. Okay, so it should be about 5 millimeters, so it covers lens around 360 degrees. So you can have a choice of any of these instruments. You can use a prata forceps, or you can have a long forceps, or you can use any of these Grishabas if you have, they're available to you. And if you have a capsule fibrosis and all those, you can use diathermy and other instruments. Okay, so the hydro has to be done with the OVD still in the eye. Now the trick here is, if the OVD is still in the eye and you do the hydro versus the adult. In adult, you have to take the viscoelastic out. You need a space there for the fluid to go so that the nucleus doesn't get pushed back. Here the nucleus is so soft, it is the layer which you're forming with the fluid actually cuts through the cortex. So trick is to keep the chamber formed with the viscoelastic, heel on GV, and go under it and just shoot. So you'll just cut it like a laser actually. It's that precise. Okay, sorry, it's gone up. Sorry, I'm going the other way around. Okay, and multi-quadrant hydration is good because if you just put more fluid in one quadrant, the nucleus will stand out, and we don't want that. And eventually, once the viscoelastic starts coming out, that's the end point, and I think you'll stop there now, right? Then you go with the IA. Either you can use a bimanual if you're used to that, or coaxial. We use coaxial, and we are pretty happy with that. But when you get stuck, we always use a bimanual. And always polish the posterior capsule so that there are no strands of the fibers left there, because once you cut the posterior capsule, you don't want any confusion. You just want to hold the capsule only, not the strands which are floating freely. Okay. Now coming to the posterior capsulorhexis, the dictum is till 7 years people do it, and some people do from 7 to 10 years. They do the PCC but don't do the vitrectomy. It's your call. In your group, if the patients are coming with VO, even after 7 years, you can go ahead and do it. It's much simpler as the age goes up. But if the patient is mentally challenged, he has head nodding and has abnormal movements, and you can't put him on the YAG later on, even if the patient is 25, 30 years of age, please go ahead and do a PCC. You will not regret. Okay, so doing the PCC again is similar to doing the ACC. If you remember this one, the dome, please do not overfill the bag. You can fill up the chamber, but don't overfill the bag. The bag has to be a little softer so that you don't push the posterior capsule back. The moment it goes more back, all the maneuvers will become difficult because you have to go vertically down to hold the posterior capsule. So you give a nick similar to what you do for the anterior capsulorhexis, but be a little gentle. And the posterior capsulorhexis will never run away. It's the anterior capsulorhexis, which is a vertical dome superiorly, which runs off. Posterior rhexis will never run away, but you can, if you're a little rigid with that, you can break into smaller fragments because it's very, very thin. And something, if you play golf, it's like putter. When you use a putter, you hold the golf club gently. You have to just hold the rhexis gently. The moment your rhexis is not being held properly with your rhexis forceps mean that you're putting too much of pressure on that, or the rhexis forceps not holding well. And if you don't do the PCC, this is what you're going to get. You're going to have a PCO in all patients, 100%. Okay, so different vitrectomy modes can be tried. I used to use Infinity, but I switched to Centurion because Centurion gives you 4,000 cuts. But even if you have a low-end machine like upper machine, it's good enough. Okay, so vitrectomy we have to do with a high cutting and a low aspiration rate. We don't want a traction, we just want to cut. And you keep cutting till actually the posterior capsule falls back, and you can see the margin of the posterior capsule going back. And the moment you do more vitrectomy, the eye gets softer and softer and starts behaving properly. Okay, now how do you decide whether this it's complete or not? So there's a trick which, if it's a ghost, you can't see. What you do is you put a sheet on the ghost. So you put a triamcinolone inside the eye, so the ghost, the vitreous which is not visible will become visible, and you can just go ahead and cut it. So it becomes very, very clear. The only thing is, if you're using this one, you should be careful that the pressure might have a spike later on. Okay, the lenses have to go into the bag, and if you're putting a single piece, it has to go into the bag. Single piece does not have any business to go into the sulcus, because it can cause more damage and more iris chaffing and all. So single piece always in the bag, and if you're putting a 3-piece lens or a capture, that can go into the sulcus. Okay, so when you're putting the IOL, the trick here is that because the posterior capsule is already open and you've done a vitrectomy, you don't want to dip right into the swimming pool, into the vitreous. So you want the lens to go in and go horizontal. So you inject the lens actually against the anterior capsule, posterior part of the anterior capsule. 1 minute? Okay, yeah. So you go inside like a plane lands. When the plane is landing, the tip goes up and you land in, and you're hitting it against the posterior part of the anterior capsule. Am I making sense? Okay. And once it goes in, all right. So we just published this technique in the European Journal of how to put safely lenses in these eyes. And when you want to finish it off, this is the last slide, you have to suture these one. You can't leave them sutureless. In fact, if you're operating outside in Australia or US, you have to put sutures in all the incisions. Whereas in India, we're not putting the side port incision. Rather than that, we use a technique which is called the dynamism of the air bubble. You put the air bubble in the eye and put fluid from the side. If the bubble is still expanding, that means your side port is still leaking. Main port has to be put suture, even if it's 2.2 or 2.75, you have to put the suture. So you put a bubble and you put fluid from the side, and if it's still expanding, that means your hydro is not complete. So if it stops expanding, it's there, right? And this bubble is going to disappear by morning, so not an issue. You give a subcons to these patients and always atropine in these patients because we want the eye to be very quiet next day. And IV decatrons only if the patient had uveitis or had a RS or had a small pupil which you had manipulated. Otherwise, that's how you finish off a pediatric cataract surgery. Okay, now